Hi, everyone. I'm Dr. Tara Graff. I specialize in hematology and oncology at Mission Cancer and Blood in Des Moines, Iowa. I'm excited to be here with you today. We'll be discussing the FDA approval of MONJUVI, or tafasitamab, in combination with rituximab and lenalidomide, a regimen approved for adult patients with relapsed or refractory follicular lymphoma, or FL. This is noteworthy because it represents the first and only CD19 and CD20 targeted immunotherapy combination approved in this setting. This presentation is sponsored by Incyte. All the information being presented is consistent with FDA regulations and guidance. Important safety information for MONJUVI will be discussed within this presentation. Let's take a look at what we'll be covering today. We'll begin with an overview of the disease state and unmet needs. From there, we'll dive into the data behind MONJUVI plus R-squared immunotherapy combination, including the InMIND study design and clinical efficacy, culminating in a review of safety and dosing. So non-Hodgkin lymphoma, or NHL, is the most common hematologic cancer in the United States. Follicular is the second most common subtype behind DLBCL, or diffuse large B-cell lymphoma. The rate of new cases of follicular was 2.4 per 100,000 people per year based on 2018 to 2022 cases. Patients with follicular often have no obvious symptoms at diagnosis. The primary signs of follicular are enlarged lymph nodes in the neck or abdomen, and some may present with B symptoms, which are fever, night sweats, and weight loss. Fatigue can be included as well. You might see lab abnormalities like an increased LDH or recurrent infections. For a definitive diagnosis, morphological assessment of a lymph node by excisional biopsy is critical. So when I'm talking to a patient, and they're asking me the differences between follicular lymphoma and diffuse large B-cell lymphoma, DLBCL is a more aggressive lymphoma. It is, needs treatment, right away, but is potentially curable. Whereas follicular is more like a chronic disease. It's an indolent lymphoma or a slower growing lymphoma where patients don't always need treatment right away. And even when they do, it's sometimes not as aggressive as what we have to use in diffuse large B-cell lymphoma. So they are different. They're not the same. They definitely have their own characteristics as well as their own, disease behavior overall. So as I mentioned, while follicular is an indolent disease and patients may live with it for years, follicular is also incurable and patients face repeated relapses and diminishing responses to treatment as progression-free survival gets shorter with each subsequent line of therapy. This trend suggests the need for more durable responses in second-line options. Notably, 20 to 30% of patients experience disease progression within 24 months of initial systemic treatment. We call these people, or this group, POD 24. And this group has relatively poor outcomes, making early and effective intervention vital. So now let's talk about MONJUVI plus R-squared in the follicular lymphoma space. So MONJUVI plus R-squared is the first and only CD19 and CD20 targeted immunotherapy combination approved for second line and beyond follicular lymphoma. So why does this matter? Well, the transmembrane proteins, CD19 and CD20, are expressed across different stages of B-cell development and also expressed during malignancy. So targeting both proteins introduces a new approach to treating patients in that second line and beyond follicular space. So let's look at the efficacy and safety data from InMIND. So the InMIND trial was a large phase 3 double-blind placebo-controlled study randomizing 548 patients with relapsed or refractory follicular lymphoma to receive either MONJUVI plus R-squared or placebo plus R-squared. Patients were stratified by several factors, including progression of disease within 24 months of diagnosis, or POD 24, and refractoriness to prior anti-CD20 monoclonal antibody therapy. The primary endpoint was investigator-assessed progression-free survival, and then secondary endpoints included PFS by an independent review committee, or IRC, overall survival, overall response rate, and safety. An exploratory endpoint was time to next treatment, which we'll talk about later in the presentation. A major point of distinction, unlike continuous treatments in the DLBCL setting, MONJUVI plus R-squared is administered for a fixed duration, so 12 cycles only. After that, treatment is complete. When we look at the InMIND trial population, it's clear this was a well-balanced and rigorously designed study enrolling patients across the full spectrum of disease severity. Importantly, the study included a broad patient population that included tough-to-treat patients. 83% had high tumor burden, meeting at least one Guelph criterion. 43% were refractory to prior anti-CD20 therapy. 32% experienced that POD 24, or meaning they progressed within 24 months after initial diagnosis. The patient population in InMIND could enhance confidence in the applicability of MONJUVI plus R squared across your patient base, including those with more aggressive disease trajectories. Let's take a closer look at the efficacy data from the InMIND trial. In the IRCSS PFS analysis, a secondary endpoint, median PFS, was not reached in the MONJUVI plus R squared arm compared to 16 months with R squared alone, with a 59% reduction in risk of disease progression or death. PFS by IRC assessment was not formally tested for statistical significance. The primary endpoint of investigator-assessed PFS showed a median PFS of 22.4 months with MONJUVI plus R squared versus 13.9 months with R squared alone after a median follow-up of 14.1 months. This translates to a 57% risk reduction in disease progression or death. The overall response rate was 84% with MONJUVI plus R squared compared to 72% with R squared alone. Now let's turn to the exploratory endpoint, time to next treatment, or TTNT. This was defined as the time from randomization to either the start of next anti-lymphoma therapy for any reason or death from any cause. This endpoint carries unique relevance in follicular lymphoma, where patients may live with the disease for many years. So, in my clinical experience, since follicular is both indolent and incurable, patients highly value meaningful breaks between therapies. So, when I look at a study and I look at its endpoints, TTNT to me is important, just like PFS is, because even if somebody starts to show signs of progression, but doesn't need to be restarted on therapy for 2 years or even longer, that's a win, right? So you can tell your patient, here's the progression-free survival. And even if you do show signs of progression, you may not warrant therapy for, X amount of time. And that gives them some hope and just, gives them some, a positive outlook, especially when they're talking about a chronic disease that they're going to need treatment for, on and off for the rest of their lives potentially. So I just wanted to highlight that that is important when looking at efficacy. So in this study, an estimated 78% in the MONJUVI plus R squared arm did not receive subsequent treatment at 2 years after randomization, compared to an estimated 57% in the R squared alone arm. It's important to note that the time to next treatment analysis was exploratory in nature and should be interpreted with caution. So when it comes to overall survival in the InMIND study, it's important to note that this endpoint was tested only for futility at the time of PFS analysis, not for statistical significance. At the time of PFS analysis, median overall survival had not been reached in either treatment arm. However, the study includes a planned 5-year follow-up, which may help clarify any long-term survival trends that may emerge over time. So before diving into specific subgroups, it's important to contextualize the data. While the subgroup analysis and InMIND were exploratory, the findings show consistency across subgroups. Across a range of pre-specified subgroups, there was a consistent trend favoring MONJUVI plus R squared, with hazard ratios steadily below 1. We'll now take a closer look at two subgroups, those patients with POD 24 or progression of disease in 24 months, and those refractory to prior anti-CD20 therapy. In the InMIND study, POD 24 again was defined as progressive or progression of disease within 24 months of initial diagnosis. Between 20% to 30% of patients with follicular fall into this category. Unfortunately, it's associated with a poor prognosis, and these patients often have features associated with aggressive disease. In some cases, patients may have transformation of lymphoma or their follicular lymphoma, which means that their indolent follicular has now become more aggressive, and that can be seen at the time of POD 24. So despite this tough to treat subgroup, PFS benefit with MONJUVI plus R squared was consistent regardless of patients' POD 24 status in the InMIND trial. Now, in this subgroup, refractoriness to prior anti-CD20 therapy was defined as patients who either didn't achieve a CR or PR to an anti-CD20 containing regimen, experienced progression during treatment, or relapse within 6 months of their last dose. This is a tough to treat population, and the PFS benefit of MONJUVI plus R squared held up, even in this anti-CD20 refractory group. So, because follicular is an indolent lymphoma, in my clinical experience, the safety profile of a treatment regimen is important to consider when making treatment decisions, right? Again, we talk about this being an indolent lymphoma and a type of lymphoma they're going to live with. So, thinking about adverse reactions, when I'm thinking about which therapy I'm selecting is important because my patients have different lives, right? Some travel and some are away for, longer periods of times than others. And they don't want something that is going to significantly slow them down in terms of adverse reactions, right? So it's important to think about those things. So MONJUVI plus R squared showed a comparable safety profile to R squared alone with a similar overall rate of adverse events of any grade and a similar rate of grade 3 adverse events. The most commonly reported side effects with MONJUVI plus R squared included respiratory tract infections, diarrhea, rash, fatigue, constipation, musculoskeletal pain, and cough. Adverse reactions that occurred more frequently with MONJUVI plus R squared than R squared alone included COVID-19 infection, pneumonia, diarrhea, pruritus, fatigue, musculoskeletal pain, and mucositis. Discontinuation of MONJUVI or placebo due to adverse reactions occurred in 11% of patients in the MONJUVI plus R squared arm and 7% in the placebo plus R squared arm. So let's talk through the dosing of MONJUVI plus R squared. As I mentioned, MONJUVI plus R squared is a fixed duration treatment. Patients complete their therapy after 12 cycles, which is very different from the ongoing maintenance model used in the diffuse large B-cell indication. And, MONJUVI is administered weekly for the first 3 cycles and then every 2 weeks for cycles 3 through 12. The infusion time for MONJUVI is 1.5 to 2 hours. And perhaps most importantly, this regimen can be administered in a local outpatient setting with no hospitalization required. MONJUVI should be administered with immediate access to emergency equipment and appropriate medical support to manage any infusion-related reactions or IRRs. To reduce the risk of infusion-related reactions or IRRs, patients should receive pre-medications 30 minutes to 2 hours before the MONJUVI infusion. If a patient does not experience IRRs during their first 3 infusions, pre-medications become optional for future doses. However, if a patient does develop an IRR, the recommendation is to continue pre-medicating before each subsequent infusion. Administer MONJUVI as an intravenous infusion and do not co-administer with other drugs through the same infusion line. We're going to discuss some important safety information. There are no contraindications to this treatment. And there are, noted infusion-related reactions with MONJUVI, so we need to be aware of those IRRs, as I was mentioning before. In InMIND, infusion-related reaction, or IRRs, occurred in 16% of the 274 patients with follicular who received MONJUVI in combination with lenalidomide and rituximab. Signs and symptoms included fever, chills, rash, flushing, dyspnea, and hypertension. These reactions were generally managed with temporary interruption of the infusion and or with supportive medication. Pre-medicate patients prior to starting MONJUVI infusion. Monitor patients frequently during infusion. Based on the severity of the infusion-related reaction, interrupt or discontinue MONJUVI. Institute appropriate medical management. So myelosuppression, right? We know that our therapies can decrease our blood counts. So MONJUVI can cause serious or severe myelosuppression, including neutropenia, lymphopenia, thrombocytopenia, and anemia. In InMIND, among 274 patients with follicular who received MONJUVI in combination with lenalidomide and rituximab, new or worse grade 3 or 4 cytopenias included decreased neutrophils in 48% of cases. There were 19% grade 4 events, decreased lymphocytes in 22% of cases, or 1.8% grade 4 events, decreased hemoglobin in 9%, and decreased platelets in 8%. There were about 4% grade 4 events in those cases, and febrile neutropenia occurred in 4.4% of the patients. So we want to monitor complete blood counts or CBCs before each treatment cycle and throughout treatment. We want to monitor patients with neutropenia for signs of infection. We can consider granulocyte colony stimulating factor or GCSF administration. And then you want to withhold MONJUVI based on the severity of the adverse reaction. So refer to the lenalidomide prescribing information for dose modifications with that drug as well when using this regimen. So we have to be aware of fatal and serious infections, including opportunistic infections incurred in patients taking MONJUVI and following the last dose. Among 274 patients with follicular who received MONJUVI in combination with lenalidomide and rituximab in the InMIND trial, grade 3 or higher infections occurred in 24% of patients, including fatal infections in 1.1% of patients. The most frequent grade 3 or higher infections were respiratory tract infections in 19% of the patients, including grade 3 or higher pneumonia in 14% of the patients and 11% with COVID-19 infection. Opportunistic infections of any grade occurred in 6% of patients, including herpes simplex or zoster infection in 5% of patients. Fungal pneumonia, so 1.1% had PCP in 0.4% of patients, and cytomegalovirus reactivation in 0.4% of patients. So you want to monitor patients for signs and symptoms of infection and manage infections as appropriate. You want to consider infection prophylaxis per institutional guidelines and consider treatment with subcutaneous or intravenous immunoglobulin or IVIG as appropriate. We have to be aware of the embryo-fetal toxicity with our medications, and based on its mechanism of action, MONJUVI may cause fetal B-cell depletion when administered to a pregnant woman. You want to advise pregnant women of the potential risk to a fetus. You want to advise women of reproductive potential to use effective contraception during treatment with MONJUVI and for 3 months after the last dose. The combination of MONJUVI with lenalidomide and rituximab is contraindicated in pregnant women because lenalidomide can cause birth defects and death of the unborn child. You want to refer to the lenalidomide prescribing information on use during pregnancy. Other adverse reactions that we need to be aware of in the MONJUVI arm are the serious adverse reactions that occurred in 33% of patients, including serious infections in 24% of patients, including pneumonia and COVID-19. Other serious adverse reactions in more than 2% of patients included renal insufficiency in 3.3% of patients, secondary primary malignancies in 2.9% of patients, and febrile neutropenia in 2.6% of patients. Fatal adverse reactions occurred in 1.5% of patients, including from COVID-19, sepsis, and adenocarcinoma. Adverse reactions led to permanent discontinuation of MONJUVI in 11% of patients and dosage interruptions in 74%. The most frequent adverse reactions leading to dosage interruptions of MONJUVI were neutropenia, 37% of all patients, 22% with COVID-19, 11% with pneumonia, and 8% with an infusion-related reaction. The most common adverse reactions occurring 20% or more of the time in patients receiving MONJUVI were respiratory tract infections, 56% of the time, including COVID-19 and pneumonia, 38% with diarrhea, 37% with rash, 34% with fatigue, 29% with constipation, 24% with musculoskeletal pain, and 21% with cough. The most common grade 3 or 4 laboratory abnormalities occurring in 20% or more of the patients were decreased neutrophils 48% of the time and decreased lymphocytes 22% of the time. Now, for a summary of today's presentation, as we wrap up, it's worth stepping back to look at the totality of evidence we now have for MONJUVI plus R-squared in relapsed refractory follicular lymphoma. We're truly excited to have another treatment option in this space. With the InMIND study, we saw that adding MONJUVI to R-squared significantly reduced the risk of disease progression or death. In an exploratory analysis, 78% did not receive subsequent treatment at 2 years after randomization, and that was estimated. The safety profile was comparable to R-squared alone. Again, this is a fixed duration regimen, and it can be delivered in the outpatient setting, enabling local access to care without any need for hospitalization. So taken together, MONJUVI plus R-squared offers an option for your patients navigating second-line follicular treatment. Lastly, important to note, Insight Cares offers support for eligible patients on MONJUVI. This support includes benefit verification and prior authorization or appeal support, information about savings and financial assistance options, and practice resources and forms. Thank you so much for joining me today.